We are joined today by Latona Giwa. She is an '09 grad. I think I have that right.
Hmm.
She's been working since leaving Grinnell. She's been working in New Orleans with pregnant and new moms as a registered nurse, lactation consultant, a birth doula. So lots of experience with pregnancy and childbirth. And in that time, she's also founded several organizations to support support families in pregnancy, childbirth, breastfeeding, parenting. So just really focused on getting new babies and their families off to a good start. Her work in this area has led her to become a leader in the national birth justice movement, which will be the focus of her talk on Thursday at the convocation, which of course you're all invited and encouraged to attend. If you need that link, let me know and I'll put it into the chat. Yeah, so I think we had talked about Latona giving a little bit of a intro to kind of how she got from, Grinnell. We don't obviously have a nursing program at Grinnell. So how did she go from, stepping foot as a first year on the Grinnell campus to doing all of this work in the area of nursing and maternal infant care? And then we will open it up for questions from all of you. So, Latona, thank you for being here.
Yeah, thank you, Mary Jane. And yeah, I just want to echo gratitude to all of you for taking the time to share this conversation with me tonight. I also have Zoom fatigue. So I know that it's a lot to ask. It's a lot of screen staring. And I won't be offended if your eyes drift off or if you're doodling. I, like Mary Jane said, I attended Grinnell and graduated in 2009. I studied sociology, spent a lot of time in the humanities and social sciences, but also did take biology and chemistry and some hard science courses. But when I entered Grinnell, I was very passionate about social justice. I took one of my first courses was in community organizing, and I just knew that I wanted to be an organizer. It felt like a calling. Two Grinnell experiences really laid the foundation for me to choose to go into maternal child health and use that organizing energy in that direction. The first one was as a sophomore, I had a summer internship in Minneapolis, which is where I'm from, working with an organization called Streetworks Collaborative that was a collaborative of social service agencies for homeless youth. And my fellow Grinnellian partner and I got to spend the summer interviewing, doing focus groups, and talking to homeless youth on the street, in shelters, at needle exchanges, things like that, to create a resource guide. And what I realized really quickly in doing that work is that almost all of the women identified folks that I was seeing were either pregnant or parenting. And I learned a truth of homelessness in the United States that that pregnancy either leads to homelessness or results from the vulnerability of homelessness for a lot of girls and women. And I immediately had these burning questions. Why would that be? How could that be? How could it be that we live in a society where what I believe to be one of the most miraculous transformations in our lives could pose a social risk, right? And we have built a society where being pregnant makes you vulnerable. And I wanted to learn more about this. I literally Googled how to support pregnant women and came upon this term doula and this term midwife, things I had not thought about before. And I, started to dive in. When I returned to Grinnell, I tried to find some support or resources to learn more about doulas, midwives, and nursing, because I was interested in nurse midwifery. And I did not come upon much support or information. At the time, the health career office was not as developed as I'm hearing that it is today, which is really exciting. But also, I think that there was a lot of a belief that Grinnellians should become doctors and not other types of allied health professionals. So I didn't get very far in that endeavor while I was at Grinnell. But my second Grinnell experience that led me along the way was that after I graduated, did a postgraduate fellowship, Grinnell Corps in New Orleans. And I got to do community organizing work in a neighborhood called Central City in New Orleans. And I was focused on meeting with residents, finding out their goals to improve the quality of life in their neighborhoods, and connecting them to one another and helping them to build collective power around those issues. But again, I had this aha and burning question, because almost all of the people that I was working with were women, mothers, grandmothers, and they were doing this work often in the name of their sons, husbands, brothers, to improve their quality of life, to change how systems interacted with them. But I wanted to know, what about you? What are your experiences? What have they been? And I started talking to these women about mothering, which eventually led to about birthing. And I was struck by the fact that it didn't matter if they were 20 or 70, they remembered their birth like it was yesterday. And it was life-changing, it was impactful, it was meaningful, and it was often really negative and really traumatic. And it wasn't something that they had ever talked about, because we don't create that space in this culture. And so from there, that launched me into, I became trained as a doula down here in Baton Rouge. And then I sought out other doulas and mentorship. That process led me to eventually starting Birthmark Doula Collective, because there just weren't a lot of doulas in the area, and I wanted community. I wanted to work with other birth workers who wanted to look at systemic change and serving the most marginalized of parents. I then went to Louisiana State University and got my BSN and became a registered nurse, with the idea that I would go on to be a midwife. After working in the hospital here in labor and delivery and lactation, I realized that I actually did not want to be a midwife, that my calling actually is organizing and advocacy, and I landed back at that. I am a person that I can't just do system organizing work, and I can't just do direct service client care. I need both. And so I feel really fortunate that I've been able to build a career now with Birthmark and the New Orleans Breastfeeding Center, the two organizations that I founded, where I get to spend a day or two a week sitting with clients, providing postpartum and lactation support. And then I get to spend the other days supporting the people who support them, the birth workers, doing training, education, advocacy, and policy work. And in my current position, I support nurses, doulas, lactation consultants, midwives, and nurse practitioners, all under the umbrella of maternal child health and birth justice. So I'm happy to talk about any of that tonight.
Questions for Latona?
I have a question. I'm not super familiar with the role of doulas versus birth wives or midwives. Can you extrapolate a little bit more on that?
I would love to. So you are not alone. Often when we are tabling or out in the community, people say, what's a doula, or what's a midwife, or what's the difference? So I love to explain that. In the Venn diagram of doulas and midwives, what is in the middle is that they are both professionals with training and certification licensed to practice in their area of perinatal health, and that they are both what we would call alternative models to what has become the mainstream obstetric model in the United States. But they are very different. A doula is more like a community health worker or an advocate for the family. I'm going to say she, because the majority of doulas are women identified, but certainly anyone can become a doula regardless of gender identity. She is intimately working with the family from pregnancy through birth and the postpartum period. She is providing informational support, physical support, and advocacy to that family, meeting with them usually in their home throughout the prenatal period. And then she does what no other perinatal health worker does. She is on call and with the family continuously from the beginning of labor until the baby is born. So what a lot of lay folk do not know, and what a lot of first-time pregnant families do not know, is that their nurse, their doula, their midwife is not going to be with them for most of labor and delivery. That they're going to come in and out of the room, check on them, but they're going to spend a lot of time alone. And the doula is with the family the entire time, continuously. And that is the greatest impact of doula support and what is really behind the huge evidence-based impacts that doulas have on birth outcomes. But she is not a medical professional in the sense that she is not a practitioner and not providing care, medical care. She is providing informational support, emotional support, and physical support. On the other side, a midwife is a healthcare practitioner. And really, a midwife is most similar to an obstetrician. She is, and I'm going to say she again, the majority of midwives identify as women, but certainly anyone of any gender identity can become a midwife. She is takes charge of the prenatal care of her clients, just like an obstetrician, provides the care throughout prenatal visits, monitoring, education, and support. And then she is there to assist with the delivery of the baby in the same way that an obstetrician would. The difference being that obstetricians are trained to manage high risk care. So if a C-section delivery is needed or certain procedures are needed, then the collaborative physician or obstetrician would step in and do that. But otherwise, a midwife is trained to manage care prenatally through the birth and into the postpartum period. And midwives also, depending on the state, provide other types of well women care and are also licensed to provide care to the baby up to 1 month of age. So we've got the healthcare provider and we've got the advocate. And what I love is when a family has both, right? It's not choosing one or the other. Ideally, a perinatal support team includes your healthcare provider, your doula, your family support, your mental health support, right? To be able to fully support the pregnant person and have the best birth outcomes.
Thank you.
Riley?
You're a lactation consultant, correct?
I am, yes.
What is that training process like?
So, and I do want to say as a caveat that in the United States, because of the very particular history of physicians trying to monopolize maternal child health care over the last century, there is a patchwork of legal arrangements for most maternal child health allied professionals, and it varies very much from state to state. But I'm going to speak to my reality in Louisiana and highlight a few variables, but it really does depend on the state. But so lactation consultants, there are a couple levels of lactation consultants. They're On the community level, there are certified lactation counselors. This licensure is very accessible, and it's designed for someone who may not have a medical background to be able to obtain. Most of the lactation professionals in my organization have this community level licensure, a CLC, certified lactation counselor. The training is short. It's about 40 hours. You take an exam, but then the expectation is the experience is great, right? So you get most of your training on the ground and through apprenticeships. And I think that I serve as a consultant to our state's Medicaid organization, and I am continuously advocating for that level of lactation training to stay the same, because we do not have enough lactation counselors in this country, particularly in marginalized communities, and we need that to be an accessible position. It's also a great certification to couple with another type of training, right? You could be a social worker and get your CLC. You could be a physical therapist and get your CLC. You could be an educator and get your CLC, right? On the other side, there's the International Board Certified Lactation Consultant, IBCLC, which is what I have. This is the highest level of lactation provider training globally, and is internationally recognized. This certification is designed for people who have some sort of medical background, whether it's a medical assistant, a registered nurse, a physician, etc. Though it can be obtained without medical training, you just have to take certain college courses. So the IBCLC requires certain college courses, about 90 hours of lactation education, and then 1,000 hours of clinical documented lactation support, which can take up to 5 years to obtain. So it's a much more involved endeavor to become an IBCLC, and I always encourage people to first get the CLC and then build up to the IBCLC. But technically, as IBCLCs, we are providers. In some states, we can bill for our time with patients, and we are consultants to other healthcare providers. So technically, physicians would ask us to consult on a lactation issue. I'm just curious, of the people who are present here, is anyone thinking about going into nursing? Is anyone thinking about doula or birth worker work?
I am. Sorry, my name's Inez. Yeah, I'm interested. Well, I thought about OB, but I'm also really interested and think it's important for us to support midwifery and doula, obviously for birth, as you've explained. So that's definitely something that I'm interested in looking into as I pursue this interest in maternal health and prenatal health, I guess. So it's really fascinating to hear the work that you've done. So I appreciate that.
Thanks, Inez. And I would love for I think I heard you say OB. I would love for every obstetrician to do a doula training.
I've actually thought about that. I've thought about how important that would be also, just in terms of being able to support your client in a different, I guess, or patient in a different way than what they may be expecting. Because I think a lot of times what I've noticed and what I've, talked to people about and seen, that a lot of OBs, it's very in and out. You don't have that strong relationship with your patient. And maybe even if your time is still limited with a patient, but having that doula training might provide a little bit more understanding and maybe better outcome, hopefully, that some people may not, be granted usually.
Absolutely. I actually believe that everyone should do a doula training because we all probably will support a pregnant person at some point in our lives, whether we will be that person, whether it'll be a family member, whether we'll support them professionally, right? And doula training is it is about the process of birth and understanding the physiology, but it is foremost about how to support pregnant, birthing, and parenting people. And frankly, as a society, we all need to be better at that. We don't live in a society that prioritizes that group of people or that phase of life. And I agree with you, Inez. I think that obstetricians and our most allied physicians in our community have taken doula trainings to become better allies and supporters. You, as an obstetrician, you probably will not be able to provide that type of support. Like you said, your time is limited and your training really is to focus on high risk interventions. And we need that, right? That's life-saving and valuable. But what doing a doula training can do is, one, make you better at identifying needs and referring to the right type of support so that family can be well supported, and help you to be a better interdisciplinary team participant, right? So obstetricians need to participate in an interdisciplinary team to be able to fully support their clients. So yeah, I think that is a wonderful idea. And certainly as a med, we have had a number of med students and residents who do doula training and do some student doula births or participate in childbirth education or lactation visits, and take that on as a chosen part of their training and their trajectory. Another thing I think is really interesting about obstetrics is that as a science, it is the least evidence-based medical science that we have. And part of that is just because of the nature of who we work with. Not a lot of pregnant people want to volunteer to take part in a study, right? This is high risk, has huge implications. But obstetrics, as a science, because of its history in the United States, is often pretty removed from the practice is often pretty removed from the evidence. And many obstetricians have never seen what we call a normal birth. Okay, so because of how medical training is done, because of how hospitals work, many obstetricians have never actually had the opportunity to sit and observe a labor from start to finish that it has not been intervened upon. And so they don't actually know what normal birth looks like. And I think that is what one of the things that doulas and midwives really have to offer, because that is what we do on a regular basis. We're trained to see the normal, and physicians are trained to see the abnormal or the illness. And as I think that regardless of what direction you head, that could be really valuable to you.
Thank you.
I saw a little.
Sorry, so something that's really been illuminated to me in my time at Grinnell, and that's become like a more popular, well-known thing, is the disparity in like birth and racial justice. And I guess like the most common fact that pops up is the disparity in birth mortality between Black mothers and mothers of other races. And I was wondering how your work related to that, because something that I'm really interested in is disparities in the medical field. And so I wanted to know how like you've personally addressed that, whether it's through working with marginalized communities directly, or whether you've actually like reached out to medical professionals or do training with them, or whatever else you have to say on that.
Yeah, thank you. So that's actually the foundation of my work and our work. Our central aim is to decrease the disparity between Black and non-Black birthing people in terms of morbidity and mortality. And you're right, for those of you who may not be as familiar, kind of the most cited statistics that we have is that Black women die at 3 to 4 times the rate of their white counterparts during or after delivery in the United States, with in some areas it being as high as 12 times as often. And then Black babies die at 2 to 3 times the rate of their white counterparts before their first birthday. So we have a crisis in the United States of maternal child health care. And I like to remind people that our healthcare system was not built to ensure the health and safety of Black people. It was built with the opposite intent. And a system that is not built to benefit everyone will inevitably hurt everyone. And so, although in addition to the fact that Black mothers and babies are dying and becoming ill at unacceptable rates in this country in the perinatal year, even white mothers and babies are also dying and becoming ill at unacceptable rates. And we can see that when we look at rankings globally. The United States is currently 55th in the world in terms of our maternal child health outcomes, 55th. So that is extremely low. We are basically lower than all developed nations and lower than many less developed nations, despite spending more than any other country on maternal child health care. So there's something severely wrong with what we're doing, and it's actually been getting worse, not better. Black women, the disparity between Black and white women in birth is worse today than it was during chattel slavery. So, Shiva, there are many ways that we are working to address this. Number one, doula work itself. So part of why I was drawn to doula work is that it is evidence-based. There is a large body of scientific peer-reviewed evidence that shows that possibly more than any other intervention, providing a family with a doula changes birth outcomes. Birth doulas are shown to reduce C-section rates by 40 to 50%. That matters not because we care whether you have a C-section or a vaginal birth, but because you're more likely to die or become ill of complications if you have a C-section. Birth doulas are shown to reduce rates of postpartum depression, shown to increase breastfeeding rates, shown to decrease the length of labor, shown to decrease the need for epidurals, inductions, and other major medical interventions that can cause complications, right? So if a quote that I like is that if a birth doula was a medication, it would be considered criminal not to prescribe it. Right? If we had a medication that we knew changed your health outcomes by such a degree, a physician would be considered criminal not to prescribe it. But that's not where we stand at this moment. We're fighting for birth doulas to obtain reimbursement from private and public insurance across the country, with the notable exceptions of Minnesota, New York City, and Oregon. So number one is just increasing access to birth doula services, training more doulas so that when we do have more access, the doulas are available to provide that support, and fighting for doulas to have just wages. So in the few states that have provided Medicaid funding to birth doulas, the wages have been dismal. As I said, we do a lot of consulting and work with our state Medicaid program. We are firmly not interested in creating a reimbursement system for doulas if it creates poverty wage jobs for those birth workers, because they then will become part of the statistics that we're trying to combat. There are so many other things that we are doing, but I would say that is number one. You also highlighted training for physicians. We do provide training. We provide grand rounds education for the local medical schools here. And we do kind of a quarterly community education process that's interdisciplinary. So physicians, midwives, nurses, doulas, social workers, all types of folks, nutritionists come, and we talk about a real live case study of someone who went from pregnancy until their baby was 2, all the different social factors that impacted them. We interview that person and use their own words, which is a flip on the traditional medical way of presenting case studies, which is with the gaze of the physician. And we really focus on racial justice and social justice issues in those case studies. So those are a couple examples, but absolutely, that is our central aim.
I'm really curious about kind of, it's part of that, but just how really we make like doulas accessible, or like kind of your process of like building a network and like making more people, I guess, like aware of even just like what they are and like how they gain access to them, particularly in areas where, yeah, like basically not cities where it seems, or not, you know, certain parts of cities that it seems easily accessible. I don't know if I phrased that well, but yeah, just kind of more access, I guess, and how you're kind of working on that and your like network.
Absolutely. So when I became a doula, doula work was not very popular yet. And there were maybe 3 or 4 doulas in the city of New Orleans, and they were all practicing individually. And they were doing what I considered to be kind of boutique doula services, right? Charging a large cash pay amount for their services that would really only be accessible to a very small group of people, right? Because I was not interested in doing that, because I see doulas as a tool for social change. That's why I started Birthwork, because I wanted to be compensated fairly for my time and also serve families who needed me most. And so by forming the Doula Collective, we were able to, initially, we didn't have any grant funding. And initially it was a sliding scale model. We used funds from people who could afford to pay more to be able to provide services to those who couldn't afford to pay more or pay at all. And we operated that way for years. The first, I would say, 4 years. There was no additional grant funding, just redistribution of wealth and making it clear to our upper income families that they could give more so that more people could access this service. And that's one thing I love about birth when I'm geeking out about it conceptually, is it is the most common hospitalization. It is 84% of people with a uterus will give birth. We are all born. It is a uniting experience. And as an organizer, I'm really interested in, and I see all the time, when people go through pregnancy, they start to see what is not making sense in our healthcare system, in our country in general. And they start to use their collective brain and see that, oh, other people are experiencing this all the time or worse than me. And they start to empathize. And I think that with the right support, and I see that when people have a positive and empowering birth experience, they become a different type of citizen, right? And they're interested in engaging with other families and helping other families to have positive experiences as well. So, sorry, that was a tangent, but sorry, what am I talking about again? Oh, access. Thank you. So yes, so we just did sliding scale originally. And then now we're a much larger organization and we have a lot of grant funding also, but I am proud to say that at least 1/3 of our funding still is directly from the community because they believe in the work. And I think that keeps us accountable to them. Additionally, though, on the other side of that, part of access is supporting the birth worker, right? This is really hard, draining, intimate, emotional work. And there is a high risk for burnout. And so to make birth work sustainable, birth workers need support. They need to be paid fair wages. They need health care and benefits. We provide childcare for our doulas, because if you're going to get up at 2 o'clock in the morning and be on call and go to a birth, who's going to take care of your kids? We provide backup, right? So we have a backup system, a primary on-call doula and a secondary on-call doula. And during the fall, when all the Christmas babies are born, a third on-call doula. And it's hard to do that by yourself. And so when I talk to people who are interested in becoming doulas all the time, and I tell them to build community, to build a collective. In addition, there's the insurance and payment side of it, and that is huge. We need to decide in this country that we're going to invest in the front end in perinatal care and not wait for people to be permanently disabled or die on the back end, right? And there is a lot of squabbling over the cost of a doula, because she might spend 50 hours, right, at a birth. She might be in that client's home postpartum every day for a week because they really need it, right? It's a time-intensive work, and studies show that doulas spend like 3 times as many hours with their clients as an obstetrician does from beginning to end, right? But the cost is more than made up for in the outcomes. I don't want to, gender anybody on here, but I am excited to see that potentially we have some men on the call too, and I think that is exciting. I think that we're starting to see a few more men become midwives, become doulas, become nurses in maternal child health, whatever that looks like, and I'm excited to see that change. That is a huge discussion, though, in the field of if that should be and what that looks like, right? And certainly an interesting conversation to have. We know that, certainly many birthing people have experienced sexual violence before, during, or after being pregnant, and people will bring that up in the discussion of what is the role of men there. But we in Birthmark, well, first of all, we just try and be very gender inclusive and just talk about birthing people in general. But we also really believe in supporting fathers and partners in this work, and I believe that is a huge missed opportunity when so often you will see a father in the waiting room and who doesn't come in during the prenatal appointment, and that's because we don't welcome him in. We don't let him know that this is a space he can be in. Especially for men of color, there are so many barriers to their participation in this, what could be life-changing experience, from things like the hospital that I worked at as a labor and delivery nurse. They required you to show ID to get into the birth room. And there were people without ID or had reasons to not want to show an ID, mostly people of color. And I always thought that was so unfortunate. We know that chemically, the experience of being in a birth room changes us. The release of oxytocin, the hormone of love and bonding, impacts everyone in that room and is part of our primal programming to become family and to connect, right? Another tangent that I'm just going off on.
I have a question. I was just interested in wondering how, as a doula and as a lactation consultant, and as someone with more training in that, how that can serve people with post-generational trauma that may be manifested in birth or surround their birthing experience, or also just lactation in general. So yeah, I don't know if that's something that you talk about or that you work with in your practice.
Could you just say who's speaking?
Oh, sorry, it's Inez, my bad. Inez.
I'm still not used to the disembodied voices of this medium. Absolutely, that is a deep question with a lot of fertile material. But birth is now. I'll say this: I'm a very science-oriented kind of type A person. I want the evidence for everything, and I believe that we owe it to our families to provide evidence-based care, to cite what we are speaking about, and to make clear when it is personal or anecdotal experience. And there's a huge absence of that in obstetrics. For some reason, when it comes to obstetrics, everyone feels like whatever my personal opinion is with my baby, that's good enough, right? It's not. But I also know from experience of being in many birth rooms and sitting with many perinatal people that there is just a lot of energy there, and there's a lot that happens that we cannot understand or explain. And I know that intergenerational trauma and experiences definitely show their head and emerge in that time in our lives. I know that from personal experience, and I know that from my clients' experiences. And a lot of what a doula does actually is sit with that. We take the time in our prenatal visits to ask families what were their last birth experiences like, to hear the birth story. We ask, what was your mother's birth experience with you, right? Because if they don't talk about it, it's still there, right? And there's so much evidence that shows the impact of fear and anxiety, cortisol chemically in the body, on the ability to birth, right? And it's so important to process that, to talk about that. When a family member enters the birth room, there can be so much trauma there. And sometimes labor stalls completely when someone comes into the room, right? Part of a birth doula's responsibility is to help the family navigate that. We talk about that before birth. Who do you want in the birth room? Who do you not want in the birth room? What do you want me to do if person A comes in the birth room, or if you feel like you need space or quiet, right? We practice, we role play with the family. We teach them how to say, I need to go to the bathroom. Can you guys step out for a minute, right? And then we'll have a bathroom conference. This comes up all of the time. There's a saying in birthwork that it's hard to become a mother when you're busy being a daughter. And a lot of that is about when we have grandma in the room and and that relationship happening. And a lot of in lactation, this is such a common issue too. A lot of the birthing person's mother had her own experience, and a lot of times it was not good. With birth, with breastfeeding, maybe she feels like she failed because she wasn't able to breastfeed. Chances are she wasn't, because generationally where we are, especially for Black women in America, but in general, most people's mothers didn't breastfeed. That was the peak of the promotion of formula in this country, which is another way that in the United States we have really failed families. That is not true in the developing world. But she brings that into her interaction with her daughter who's becoming a mother. And there can be a lot to process there, right? So as a Black lactation consultant, we talk about this a lot. Oftentimes our clients are being supported by their mother. That's very common. And their mother might be posing obstacles and barriers and saying things that are very discouraging to her. There's actually a really interesting study where they compared the number of times that a new mother spoke to her mother in the first 2 weeks postpartum. And it was the more phone calls she had, the less likely she was to keep breastfeeding. A direct correlation, which is sad. It's not a statement about those mothers. It's a statement about the way that we cared for birthing people in the past decades, right? But if we can bring her in, I love to say to grandma, because a lot of times we'll just ignore grandma. We'll ignore the father. We'll ignore the family members in the room. And that's not going to serve anyone, because I'm only here for an hour and she's with you 24 hours a day or whatever it is. So I'll say to her, what was your experience? And I will provide some sort of affirmation. And I will remind her that she is this person's number one support, right? And just acknowledging that can really shift dynamics in a family. Is anyone, I'm curious, thinking about going into kind of policy, public health type work related to maternal child health?
I'm thinking about going into public health for maternal and child health.
Who's I?
My name is Taylor Powell, sorry.
Great.
I actually had a question about that, of like what you thought of someone going into that field, but there's like so many possibilities that we could do. And like, of course, being a doula is one of them, but like what someone could do after going into public health with that concentration and like what we could make of that.
There's so much work to be done in that area. And let me tell y'all, the resources available to do that work have kind of blown open in the last decade. So when I first started doing this work 11 years ago, like I said, there weren't very many doulas. There weren't as many midwives, and people didn't know what we were talking about. Even, physicians didn't know what a doula was. And there was not very much attention to the maternal health crisis in this country. But I would say in the last few years, there has been so much media attention to the horrible statistics. There have been a couple really, really high profile investigative reports that have really targeted hospitals. And I think that though there was a lot of outcry from hospitals about it, I think that really kind of blew this open. This happened across the country, but where I live, the hospital that I used to work at and used to do labor and delivery at was featured in a national USA Today article saying, and they asked the question, why do more Black women die in your hospital every year than any other hospital in the state? And hospital administrators, insurance companies, and providers have had to pause and answer that question, right? And let me focus on your question, sorry. And so there is now a kind of a rush of funding, of support, of interest. We see senators and Congress people talking about maternal child health. I almost fell off my chair with excitement when Kamala Harris in a debate referenced one of our doula clients that was featured in the New York Times to talk about this maternal health crisis, right? So people are finally listening, but that means now we can really do work that makes change, right? Some of that work is documenting. There has been a dismal amount of documentation until just 5 years ago, it wasn't even mandated for states to record and track the number of maternal deaths that occur in their state, right? So I am honored to serve on Louisiana's pregnancy-associated mortality review board, and every state is now required to have one where they review all the death certificates and medical records of each maternal death and determine whether it was preventable or not and what was the cause. And that we just need the data to begin with to make change, right? We need to know what's happening. So there's the data side and the epidemiology, which is so important. There is, legislative and policy changes. There's the hospital level. So much change needs to happen on the hospital level. And then there's community perinatal support, which is my number one passion. But you don't need to be a birth worker. You could be someone who supports and organizes birth workers. We also need people on the insurance side. We are not going to get very far if we don't get reimbursed for the work that we do. So I'm excited that you're interested in that.
Thank you.
I think we probably have time for one more question if there is one.
I'm gonna post the convocation. It's very long. I believe this is the right link though, to register for the convocation presentation. Thursday at noon, correct? Noon Central, Grinnell time.
Correct. Great. Well, and also, if anyone is interested in learning more about my organizations or the work that we do, I'll also add in the chat those websites.
This is Inez speaking, but are there opportunities or are there ways to connect with you in the future if we're interested in, I mean, obviously this week we have a lot of information that you'll be sharing with us and on your work, but is it just like these, like your website and the NOLA Breastfeeding Center, are those ways if we're interested in maybe learning more about the work that you do or connecting with you?
Mary Jane, is there one more spot available for those interviews?
Yeah. We have. Do you have a preference for the time though, Latona? Did you?
Probably the times I sent my
Morning. If you would like to speak next week with like a 30-minute one-on-one, let me know. We do have one more, two more, one more. I think it depends on the just yeah. Let me know, and we will try to squeeze you into one of those sessions. You can just email me. Put my email in the. You probably get a lot of email from me, and don't need it, but I'll put it in here. So you can email me, and I'll double check with what kind of schedules. I just don't have those up right now.
Thank you.
Yeah, but otherwise, yeah, in the future, I'm happy to provide support or information to folks that reach out to me, and doing so via those organizations is a good way.
I was curious, are you aware of other similar types of organizations in other states or in other parts of your state? How unique are you, or how common is this model? I mean, obviously there are doulas everywhere, but kind of like this collective model to try to, one, impact public health, but two, get reimbursement and get fair wages. How frequent is that?
So there is not an organization like ours in every state. Certainly there are a few spread out in the United States that we are in community with and collaborating and organizing with. So, for example, in New York, in Texas, in Minneapolis, I actually just learned that someone who works at Grinnell, a facilitator of the Black women's group, Jasmine Brooks, is a founder of a doula collective in Iowa City. So the work is growing, the work is spreading. We are, I believe, and I have yet to find, we are the only cooperative birth worker organization in the country. So we're a member-owned co-op, which is another topic that I could talk about for an hour because I'm very passionate about cooperatives and that type of organizational model. So we're not a 501c3 and we're not an LLC. We're member-owned, which means that we really take responsibility and ownership over the direction and leadership of our organization. So in that way, we are pretty unique.
I mean, it's excellent. Thank you so much, all of you. It was a great conversation. I hope you enjoyed it. I hope to see everybody at the convocation in the little tiny boxes.
Right. Thanks, everyone.
Thank you. Have a good evening.
Well,
Thank you.